Welcome back to the deep dive. Our mission today is pretty critical. We're tackling the pharmacology of blood pressure control, specifically Chapter 43, Drugs Affecting Blood Pressure.
Yeah, this is foundational stuff.
Absolutely. If you need to master how to manage hypertension or even hypotension in a high-stakes setting like nursing,
Yeah.
this is it. We need to get a handle on how the body controls pressure and then how we can, you know, step in with drugs to manage it safely.
It's the perfect mission. The whole cardiovascular system is basically a closed plumbing system under pressure.
Right.
And maintaining that pressure is everything for getting oxygen and nutrients where they need to go. To get the drugs, you first have to get the physics. There are really three key variables.
Okay, so the first one has to be the driving force, the pump itself.
Exactly. That's your stroke volume, how much blood the heart shoves out with each beat. Then you have the resistance that blood meets on its way.
Peripheral resistance.
Peripheral resistance, yeah. And that's almost entirely controlled by the muscular arterioles, these tiny little arteries. When they clamp down, resistance just skyrockets.
And when that pressure stays high, that's hypertension. And if it drops so low that things aren't getting delivered, that's severe hypotension.
Or even worse, life-threatening shock. So you got this system that's constantly being challenged. You stand up, you run, you lie down. Before any drugs are involved, the body has these two brilliant control systems running constantly.
Okay, let's unpack this. Let's start with the immediate one,
Right.
the fastest safety net. Like when you stand up too fast and feel a little dizzy for a second, what's happening there?
That's the baroreceptor reflex. You have these specialized pressure sensors, the baroreceptors, mainly in the arch of your aorta and in the carotid
In
arteries.
your neck.
Right. And they're just constantly measuring how much the vessel is stretching. They feed that info back to the cardiovascular center in the medulla.
So if I jump up, blood pools in my legs for a second, pressure drops, and those sensors, they aren't stretched as much. What happens then?
That lack of stretch is an alarm bell. It sends a pressure low signal to the medulla, and the medulla's response is instant. It fires up the sympathetic nervous system to do two things at once.
Okay.
It cranks up your heart rate and contraction force, so more stroke volume, and at the same time, it causes this generalized vasoconstriction all over your body.
Which spikes the peripheral resistance.
And boom, your BP comes right back up and you don't faint. If pressure is too high, it does the exact opposite. It's this beautiful, fast-acting feedback loop.
That handles the moment-to-moment stuff, but blood pressure is also tied to fluid volume, right? The long game.
And that brings us to the really powerful system, the Renin Angiotensin-Aldosterone System, or RAAS.
The RAAS is a big one.
It is. It's a cascade, but it's one you absolutely have to know. It all kicks off when the kidneys sense that blood pressure is too low.
Okay, so the kidney is the trigger.
The kidney is the trigger. Its cells release an enzyme called renin. Think of renin as the master switch that starts the whole chain reaction.
So renin is out. Where does it go?
Renin finds a molecule made by the liver called angiotensinogen, and it converts it into angiotensin I.
Angiotensin
It's
first.
still just an intermediate step. It's not active yet.
Yeah.
From there, it travels mostly to the lungs, which is where the key enzyme lives,
Yeah.
ACE, Angiotensin-Converting Enzyme.
And ACE turns angiotensin I into the really potent form, angiotensin II. This one sounds like the main villain in the story.
It really is, at
Yeah.
least when it comes to chronic hypertension. Angiotensin II is a powerhouse. It does two huge things. First, immediate, really intense vasoconstriction.
So raises BP fast.
Instantly.
Yeah.
But second, and this is crucial for long-term volume control, it tells the adrenal cortex to release aldosterone.
And aldosterone means the body holds on to salt and water.
Precisely. Aldosterone goes to the kidneys and says, don't let go of sodium and water. This increases the total blood volume, which raises your BP over time. The whole system is designed to save you from, bleeding out. But when it's always on,
It becomes the problem. And that's why hypertension is called the silent killer. You don't feel it, but it's just quietly wrecking your body. Coronary artery disease, stroke, renal failure.
it's devastating. And what's so wild is that for 90% of cases, it's called essential hypertension.
Meaning we have no idea what the specific cause is?
No single known cause. And that right there is the key clinical insight. We can't cure it, we can only manage it, which is why we have to be so methodical with the step care approach.
And that starts, thankfully, before you even open a pill bottle.
Always. Step one is lifestyle changes, lose weight, stop smoking, cut back on salt and alcohol, get some exercise. If that doesn't work, and you have at least 2 high readings on 2 different days, then we move to step 2.
Adding drug therapy.
That's right.
And speaking of therapy, it's not one size fits all. We have to talk about cultural and lifespan factors. For example, How does this look different for African American patients?
This is a vital point for nurses. African American patients are at a higher risk, and they often respond differently to the drugs. They tend to get better results from diuretics and calcium channel blockers.
And less from the RAAS drugs.
Less effective, yeah, when used alone. So often, treatment for them will start with a diuretic. It's a
Yeah.
crucial consideration.
And for older adults, the main worry is safety, right? Falls.
Exactly. They're more susceptible to toxic effects anyway, maybe because of kidney or liver function slowing down.
Uh-huh.
But the real danger is if they get dehydrated, maybe a stomach bug or it's a hot day, their BP can just bottom out.
And that leads to dizziness, fainting, a broken hip.
A very serious risk.
Okay, let's get into the drugs themselves. Let's start with the ones designed to shut down that RAAS system we just talked about. The ACE inhibitors. Captopril is the prototype here.
Right. They block that ACE enzyme, the one in the lungs. So you never make angiotensin II.
So no intense vasoconstriction and no aldosterone release.
Which means lower peripheral resistance and lower blood volume. They're cornerstone drugs for hypertension, heart failure, and protecting the kidneys and diabetes.
But they come with that one really famous side effect, the cough.
Ah, the unrelenting, dry, hacking cough. It happens because ACE also breaks down another substance in the lungs called bradykinin. You block ACE, bradykinin builds up, and it causes irritation.
And people will just stop taking their medicine because of it.
All the time. And for safety, remember captopril should be on an empty stomach. But the biggest, brightest red flag,
Pregnancy?
it is absolutely contraindicated in pregnancy, can cause very serious fetal harm.
So if the cough is a deal breaker, that's where the next class comes in, the ARBs, or Angiotensin II Receptor Blockers, like losartan.
Exactly. ARBs were basically invented to solve the cough problem. They let the body make angiotensin II, but they block the receptors it's trying to connect to.
So the villain is there, but he can't get in the door.
Perfect analogy. It can't cause vasoconstriction or trigger aldosterone release. And since ACE is still working just fine, bradykinin doesn't build up and you don't get the cough.
But it shares the same huge warning.
Absolutely. ARBs are also a definite no-go in pregnancy. And then there's the newest one, a renin inhibitor called aliskiren.
That one just stops the whole cascade before it even begins.
It blocks the very first step. The risk to watch for there, which is common with a lot of these RAAS drugs, is hyperkalemia hypotassium.
Got it. Okay, so that's disrupting the RAS cascade. What if we want to target the arteries themselves, their muscle tone?
Then you're moving into the calcium channel blockers, or CCBs. Diltiazem is a great prototype.
Then how do they work?
Well, calcium is the signal for muscle to contract. CCBs block calcium from getting into the smooth muscle cells of the heart and arteries.
So the muscle can't squeeze as hard.
Right. So you get three big effects. The heart's contractility goes down, the heart rate slows a bit, and most importantly, for blood pressure, the arteries relax and dilate. It's a powerful way to lower BP and the heart's workload.
This class has a couple of really critical nursing alerts. One is about how you give the pill.
Yes, this is so important. A lot of these, like diltiazem, come in sustained release or extended release forms. You cannot cut, crush, or chew them.
Why not?
Because you break the release mechanism. The patient gets a massive toxic dose all at once and then nothing for the rest of the day. It's incredibly dangerous.
And the other one is a food interaction.
The grapefruit juice rule. For some reason, grapefruit juice messes with the metabolism of these drugs and can raise their concentration to toxic levels. So no grapefruit juice, ever.
Okay, we've hit the big RAAS blockers and CCBs. But we can't forget the workhorses of that stepped care approach.
Not at all. We have to mention the diuretics and the sympathetic nervous system blockers.
Diuretics are often first in line, right?
Very often. They're simple and effective. They just make you excrete more sodium and water, which reduces your total blood volume. Less pressure. It's a very clean mechanism.
And the SNS blockers. They're basically working against that fast-acting baroreceptor reflex we talked about at the beginning.
Precisely. You have your beta blockers, which slow the heart rate and reduce its force, cutting down cardiac output. And you have alpha blockers that work out in the periphery, causing vasodilation directly. They're all crucial tools.
And what about for a real emergency? A hypertensive crisis?
For that, you pull out the big guns. Vasodilators, like nitroprusside. It's given IV and acts directly on the vascular smooth muscle for just potent, rapid vasodilation.
But it has a scary side.
It does. It can metabolize to cyanide.
Wow.
So the nurse has to be watching like a hawk for signs of cyanide, toxicity trouble, breathing, confusion, headache. You have to stop the infusion immediately.
Okay, let's flip the script. We've covered bringing high pressure down. What about bringing dangerously low pressure up? Hypotension.
For acute shock, We need to raise pressure fast. We use sympathetic adrenergic agonists, also known as vasopressors, like norepinephrine. They cause intense vasoconstriction to get that BP up immediately.
But what about for chronic orthostatic hypotension? The kind that makes it hard for people to even stand up.
For that, we have specialty drugs like midodrine and droxidopa. Droxidopa is interesting. It actually gets converted into norepinephrine right in the body.
So it acts as a pressor agent.
Yes, but this class comes with a really critical safety rule. You should never, ever give these drugs to someone who is bedridden.
Why is that?
Because if the patient is lying down, if they're supine, the drug can cause severe supine hypertension. Their blood pressure can shoot way too high, putting them at risk for a stroke. You only give it during the day when they are up and moving.
That's a huge safety point. Okay, let's synthesize all of this. If you're the nurse at the bedside, what are the 3 absolute non-negotiables?
Okay, first, get your baselines before you start. You need renal function, liver function, and you absolutely must get orthostatic blood pressure readings.
Lying, sitting, and standing.
Yes. Second, you have to monitor constantly for fluid loss. A little bit of vomiting or diarrhea in a patient on these meds can suddenly become dangerous symptomatic hypotension.
And what was the last one? Something about surgery.
The surgical alert, yes.
Yeah.
If your patient is on an ACE inhibitor or an ARB, you have to mark their chart. You have to tell the surgical team.
Why?
Because those drugs block the body's main way of compensating for a drop in blood pressure. So under anesthesia, or if they lose blood, their pressure can crash, and it can be really hard to bring back up.
Wow. Okay. So it really clarifies how we're essentially hacking the body's own control systems.
That's exactly what it is.
Mm.
We're either reducing volume with diuretics, calming down that fast sympathetic response, or we're disrupting that whole RAAS cascade.
And since we don't even know the cause for 90% of cases, pharmacology is really our primary defense against all that long-term organ damage.
It is. And it requires really thoughtful, patient-by-patient application of these different drug classes.
Which leaves us with this final provocative thought for you to consider. Since we lean so heavily on this stepped care approach, because the cause of essential hypertension is a mystery, what other factors, beyond the usual suspects like salt and genetics, might be driving this huge societal problem? Think about unexpected environmental stressors or other physiological quirks. It's a fascinating puzzle. There's always more to learn. We'll catch you on the next Deep Dive.